Welcome students to the session of orthopedics. We'll be going through some important topics in the field of orthopedics, and one by one I will be telling you about them. First session we'll talk about the fractures, which is an essential part of orthopedics. Fractures of the upper limb and lower limb will be discussed in this session. Coming to a basic thing of fractures. A fracture is defined as a break in the continuity of the bone. The further classification of fractures can be according to types of fracture, that is divided into traumatic or pathological. Further, the traumatic fractures are according to different modes of injury are divided into direct or indirect. The direct is possibly because of assault or road traffic accidents, and indirect is most commonly because of a fall. Other ways it is classified as types of fracture is either it is simple or closed or compound or open. That is, the skin is intact in a simple fracture, while in compound it is exposed to the external, or there is some wound which is present. The other modes it can be classified according to is, it can be according to mode of treatment. The treatment can be divided into conservative or operative. The conservative treatment is usually a close reduction of the fracture with cast application, that is a plaster, is applied, while in operative either by close maneuvers or by open reduction and the help of K-wires or wires, plates or screws, or it can be even nails. These are the usual implants which are used for operative management. There are various fractures. We go for the upper limb, that is fractures ranging from clavicle, the shoulder, the arm fractures, the forearm elbow fractures, the forearm fractures, the wrist and the hand. Coming to the upper limb, firstly we talk about the Colles fracture, which is an important fracture in the upper limb. The fractures of Colles fracture is defined as the fracture of the distal end radius at the corticocancellous junction, which is about 2 centimeters from the distal articular surface. This fracture was described by Abraham Colles way back in 1814. At that time, the X-rays were not even discovered. These fractures are most commonly seen in adults, more over the age of 40 years. The most commonly seen fractures are in women who are mostly postmenopausal and who have got osteoporosis. This fracture has got classically a dinner fork deformity. The radial styloid comes to the lie at the same level as the ulnar styloid process. Just as a fork at home, the shape of the deformity is exactly like a dinner fork. Seeing in this picture diagram, you can see the distal part has been displaced upwards dorsally, and it looks like a dinner fork. The Colles fracture has got various displacements, and its fractures are as follows. One is the impaction, second is dorsal displacement, dorsal tilt, lateral displacement, lateral tilt, and supination. So we have to correct all these displacements when you are doing the reduction. The aim of management of this Colles fracture is to restore the fully functional hand with no residual deformity. So the treatment can be in the form of conservative management or operative management. The Colles fracture is treated conservatively by the close manipulative reduction or close manipulative method with cast application. It is in the form of Colles cast, which is usually done below elbow cast, right below the elbow, extending to the distal crease, leaving the thumb and the fingers free, so that person can move the fingers freely and there is reduction in swelling and there is no pain. The indications for fractures or operative management are extensive comminution if there is an impaction and if there is a nerve entrapment involvement, especially the median nerve. The modalities of treatment are in the form of close reduction and percutaneous spinning in the form of K-wires, The other open reduction is in the form of plate, that is the Ellis plate fixation. And lastly is the form of external fixator. One of the external fixator is JES, that is Joshi's external stabilizing system. This helps in fracture fragments are held in a position with the help of ligamentotaxis. The ligamentotaxis is the method of stretching the soft tissue as well as the bone and getting an accurate reduction. These are X-ray pictures of fractures of distal end radius seen here, and this is treated by the different modalities, that is the percutaneous K-wire or K-wire technique, where you don't have to open the whole joint. They can do the open reduction with plating, that is the T or Ellis plate. And lastly is the external fixator in the form of JES. You can also combine two methods, like this is the K-wire as well as the external fixator. Coming to complications of the Colles fracture is the malunion is the most common fracture complication. That is, the fracture has not united in its anatomical form. The other complications being rupture of extensor pollicis tendon. Sudex osteodystrophy is one of the complications where the patient has severe pain throughout, especially at the wrist. Frozen hand shoulder syndrome. Carpal tunnel syndrome, involvement of the median nerve. And lastly, quite rare, but it's possible to get non-union. Coming to the second important fracture of the upper limb, that is the fracture of the clavicle. There are specific peculiarities of the clavicle in the form of it is a S-shaped bone. It is the first bone to ossify in the body. Third point is it is having two primary centers of ossification, 7 secondary centers. Only long bone which lies horizontal in the body. Only long bone which ossifies from a membrane. Malunion is very common for this type of fracture. These are very, very important characteristics of clavicle, and it can come as a MCQ, so it's important to recollect these points and peculiarities of clavicle. The mechanism of injury of clavicle is a direct fall on the point of the shoulder, most commonly seen form of injury, and direct trauma over the clavicle due to road traffic accidents is another reason of this injury. Lastly is indirect fall on outstretched hand. Fractures of the clavicle is commonest site is the fracture is the junction of the medial 2/3 and lateral 1/3. That is the soft point where mostly the fracture occurs. It can also occur medially or laterally, but most commonly it is at the junction of the medial 2/3 and lateral 1/3. Fracture is almost always displaced when the lateral fragment is pulled downwards and the medial fragment gets pulled upwards because of the sternocleidomastoid muscle medially. The sites of fractures are the most common is the junction of the middle and outer third accounts for almost 85%, while the medial accounts only for 5% and lateral end accounts for 10%. So in this also the MCQ could be that the middle is the part which has got maximum place where the fracture occurs. The clinical features of this fracture are mainly the symptoms and signs of the fracture are the pain, person has got pain, comes with swelling and a classical deformity. He has inability to move the shoulder which is affected or the side which is having the fracture, example the right clavicle. So he cannot move the right shoulder very well and he cannot abduct it completely. Rarely there could be pseudo paralysis of the affected arm. The investigations of choice in this is plain X-rays, that is radiographs taken in the antero-posterior view, especially focused on the clavicle. Coming to the treatment part, it is mostly in the form of conservative manner. Rarely it is operated. All these fractures can range for from children to adults. The conservative methods of treatment are usually a cuff and collar sling, where the affected side and the arm is kept in a sling for support and relaxation. You can also do a strapping of the region where it is kept in the position, and the most commonly done is the figure of 8 with the help of bandages. It can be done in a form of a figure of 8, exactly like a number 8 it is done. If in case the conservative managements are not working, if there is maybe displacement or non-unions, or we can also do the operative methods, which are in the form of intramedullary fixation with the help of K-wires. Nowadays there is also new titanium elastic wires which are put in the clavicle, and secondly this is a plate fixation with the help of screws. Now we do this only in few indicated cases. Example, in open fractures, that is when there is compound injury and the patient skin is exposed. Secondly, if there are important neurovascular bundles which are just below the clavicle, the subclavian vessels, artery and nerve is just inferior to the clavicle. Secondly, fractures which are penetrating the skin from below outwards. If there is a non-union, it's very difficult to do in conservative manner, and it has to be done by operative technique. If the fracture is very close to the acromioclavicular joint, that is this shoulder joint, which is very good, so we have to fix it well so that the person gets good range of motion later on. If there is a shortening which is more than 2 centimeters, so that is quite significant, so you need to do some kind of manner in the form of K-wires, the nails, or the plating. The K-wires and plating are definitely minimally invasive and lesser chances of infection will be there in such techniques. But the accurate and important point is that it has to be a good anatomical reduction. And finally, if there is a gross displacement of both the fragments, it's very difficult to get in the closed manner and it will not unite in the anatomical position. Coming to the third important fractures on the upper limb is the supracondylar fractures of the humerus. This is the region just above the elbow joint, and that is very commonly seen in the children age group, especially from around 5 to 8 years old. The common thing is that supracondylar fractures are divided into two types, that is the extension type and the flexion type. The extension type is mostly the commonest type, which is almost 95% of the time it's extension, and flexion is only 5%. So this also could be an important question and MCQ, where the extension is the commonest type of supracondylar fractures. The diagnosis of this fracture is very important, and we'll go through that points. First is the history of injury. How did he get? That is usually a fall. The child falls down on the outstretched hand is very common. The clinical features of this type of fractures is there will be of course pain, but there will be swelling. There will be ecchymosis, that is redness and erythema around. Deformity will be obviously seen to the patient as well as the parents. Tenderness on palpation, there will be tenderness at the point. Crepitus, that is a form of crackling sound which is seen while there is movement or on pressure. Usually the child will not allow the examiner or doctors to even touch because in severe pain, and there is definitely limitation in movement of the elbow or the upper limb. It's very easy to diagnose it. Is you have to do a X-ray in the form of taking the elbow. The fractures can be diagnosed with the help of the radiographs, which we have to do. The affected side X-ray of the elbow must be taken in the form of anteroposterior as well as the lateral view. Most commonly the X-rays are done by anteroposterior and lateral view, and you must always rule out, very important, is the nerve and vascular injuries, because all vascular and important structures are there at the elbow in the form of brachial artery, median nerve, the ulnar nerve is very commonly present over there, and even the radial nerve. So you must take care of this, and you must palpate distally the pulse of the patient, especially the child. Otherwise you may miss you may see the fracture, but you may miss on the vascular or nerve injury. So the careful neurovascular examination must be done in both the type of fractures, especially the extension type of supracondylar fractures. The brachial artery may be lacerated by the proximal fracture fragment, and a compartment syndrome is very commonly developed. That is, the whole arm get this massive swelling all over the arm and forearm. It's very commonly missed. It's usually the child goes to bone setters or quacks and they don't do adequate reduction, as well as the treatment is not done properly. So compartment syndrome is quite a deadly complication, and God forbid anyone gets that, the child may have to undergo sudden procedure in the form of even amputation. All the major nerves I had mentioned, that is the median nerve, ulnar nerve and radial nerve, all are commonly affected because the fracture fragments are very close to the elbow joint. Coming to the treatment part of these humeral fractures, it's similarly divided into all our treatments are divided always into conservative management and operative management. In the conservative management is in the form of any slab or cast, and operative in the form of again the wires, plates and screws. So the conservative management is done with the help of hanging arm cast or a splint, which can be easily applied above elbow, that is just above the elbow. It is done on the dorsal or posterior aspect of the arm, extending almost to the wrist, again keeping the fingers free, and it is extending almost from the wrist to the upper part of the arm. So that if it is an undisplaced fracture or simple fracture, it can be definitely treated in the form of a splint, which is also called as a slab. Later on you can also reinforce into a cast. If the swelling is not gross, you can do a cast application immediately, but the reduction must be done in an anatomical manner. If there is not good reduction and you're not getting if the fracture pattern is very difficult or the grading is much higher, you must go in for operative management in the form of internal fixation with the help of K-wires. Usually in supracondylar fractures, it is done by cross K-wire technique. That is, both the pins go into like a cross. So it fixes the fracture accurately, and secondly, the K-wire must be always perpendicular to the fracture plane so that you get a good hold. Sometimes the K-wires must be reaching to the opposite end, to the opposite cortex. It must have a good hold so that the K-wires do not back out and have a problem later on. You must take care of definitely of the neurovascular structures. I already mentioned that's the median ulnar nerve when you are doing these procedures. If there is a neurovascular damage, you must have to open. There may be a kinking of the artery or any nerve which has to be released and taken care of. Coming to the fourth important part of these upper limb fractures, that is fractures of the forearm. There are various fractures of the forearm that is involving the two main bones, that is the radius and the ulnar bone, which are in the forearm. Both are equally fractured at different ends. It can be at the lower end, it can be in the middle as well as in the upper part. That is, either you can call it distally, middle as well as the proximal part. The important types of fractures which are the special types in the forearm, which may come in again as a MCQ, is Monteggia fracture dislocation, and second is the Galeazzi fracture dislocation. They are very closely related, but there is a slight subtle difference in both, and that could be very tricky for you all. So let's come to the Monteggia fracture dislocation. Is a fracture of the proximal end of the ulna with dislocation of the radial head. That is, the radius is divided to the head, the shaft section and the distal end. So the radial head is the proximal part which gets dislocated, and there is proximal end third ulnar fracture which is seen in Monteggia. Secondly is the Galeazzi fracture dislocation, where there is fracture of the distal end of the radius with dislocation of the distal radioulnar joint. So there is fracture of the radius as well as dislocation of the distal radioulnar joint, which is seen in Colles. I would again enforce you to go through this because it is quite oftenly asked question. This is a diagrammatic picture of Monteja fracture, where you can see a fracture which is seen of the ulna proximal, and there's a dislocation of the proximal radioulnar joint. This has been properly fixed, where reduction has been done and open reduction and plate has been applied. So you can see a good anatomical reduction of this fracture, and also the articular reduction is good. Even the radial head has come back to its place. This is the Colles fracture dislocation, which is, I just mentioned, is the fracture of the distal third radius, and there is a distal radioulnar dislocation. Again, it is treated with the help of plating. This is the treatment done in the form of open reduction and plating, and sometimes we may have to fix a K-wire for the distal radioulnar joint so that it is fixed, and you can remove the K-wires after around 6 weeks time. So the treatment is that fractures of the forearm may result in severe loss of function if not adequately treated. Open reduction and internal fixation for displaced diaphyseal fracture in the adults are generally the accepted and the best method of treatment. The part of the bone is divided into 3 parts also, that is the epiphysis is the growing end and which is at the end. Second is the metaphyseal region, and lastly is the shaft is the diaphyseal region. So this is again how the bone is divided into epiphysis, metaphysis and diaphysis. So usually these fractures are in the diaphyseal section. So students, we come to the end of this fracture session and spoken about the upper limb fractures. We have discussed about fracture in general, what are the fractures, its classification. Then we have come and spoken about the Colles fracture, the clavicle fracture, the supracondylar fracture humerus, and the forearm fractures.